Good morning. Thank you for coming. It's a lovely day outside, another lovely day in Florence, another day at the ATTD. I'm delighted to welcome you at this Ypsomed-sponsored symposium. It's about the CAM-APS-FX, My Life CAM-APS-FX, which is a system for closed-loop insulin delivery across all ages, including pregnancy. We have a fantastic speakers prepared to share with you the data they collected and also the experience which they had with the closed-loop systems. So we will be starting with Dr. Emma Wilmot. She will be talking about the hybrid closed-loop for all. I just want to say I am the person who developed the CAM-APS-FX, and it is very close to my heart. And when we started working on the closed-loop system, we wanted to include all the population, very young children, and also we work with pregnancy. So Emma will share with you some of the data coming from these studies. We will follow with Dr. Leah Bali. Another challenge which we have is carbohydrate counting. And carbohydrate counting is sometimes challenging, it produces additional burden, so we will see what can be done with simplified meal approach. And finally, exercise. Dr. Ottmar Moser will talk to you how to manage exercise with CAM-APS-FX. So please welcome Dr. Emma Wilmot. She is an associate professor at the University of Nottingham. She is a founding member or one of the important members of DTN in the UK, and she will share the experience of the CAM-APS across all ages. Emma, please. Thank you.
Thank you, Roman, and thank you everybody for getting up early to get in for one of the first sessions. So, we're looking at the impact of hybrid closed-loop therapy on people living with diabetes across the spectrum. These are my disclosures. So, I'm going to speak a bit about the transformation in care that we are seeing as a result of automated insulin delivery. 10 years ago, if you'd asked me whether we'd have access to this on the scale that we do now, I just would not have been able to believe where we are today. And I'm really excited. I'll be sharing a case today just to give you some insight into the impact that this technology has on people living with diabetes. I'll walk you through some aspects of My Life CAM-APS, so you've got a more detailed understanding of the opportunities that it presents. We're going to be looking at improving glycemic control across the spectrum, looking at the case of pregnancy, where really tight glycemic control is really important, and then thinking about somebody where more relaxed and a gradual improvement in control may be required. Now, let's think back. We have seen huge changes in diabetes care in the last 50 years. The mind boggles to think that one time we were expecting people to pass urine onto a stick to guide their insulin dosing. We've moved through blood glucose monitoring, and we're now at the point where real-time CGM has become a reality for people living with type 1 diabetes in many countries. But let's be honest, type 1 diabetes is one of the most challenging conditions to manage. Pratik Chowdhury and myself looked at some real-world data from Freestyle Libre users across the UK, and 16% were able to achieve the international consensus recommendations of greater than 70% time in range and less than 4% time below range. And to me, that screams at the fact that we need more to support people living with diabetes to achieve the targets. And that's where automated insulin delivery comes into its own, the future of diabetes care, and hopefully by the end of my talk, you'll have some insight into why that is. Now, Roman Hovorka has dedicated his life to developing, testing, trialling closed-loop systems, as have many across the globe. And here we have the systematic review and meta-analysis summarising the findings of some of the key studies, demonstrating a 12% increase in time in range and a 0.38% increase in HbA1c, both clinically significant improvements. But actually, I would argue that this doesn't reflect what I'm seeing in clinic. The experiences I've got in clinic are even more dramatic than this. And in the NHS, led by NHS England and Partha Carr, they rolled out hybrid closed-loop therapy to many people living in England and the UK. And Tom Crabtree, my research fellow, drew the data together and had a look at the real-world outcomes associated with the use of automated insulin delivery. To To be part of this pilot, people were already on pump therapy, they were already using the Freestyle Libre, and they had an elevated HbA1c above 8.5%. Overall, we included 520 individuals in this observational study and looked at the outcomes at 6 months, looking at a range of different outcomes. A dramatic improvement in HbA1c of 1.7%, and again, for me, this reflects what I see in my clinical practice when I take somebody with a high HbA1c across to this technology, improving from 9.4% to 7.8%. Time in range improved from a baseline of 34% up to 62%, and you'll probably reflect that 62% is actually quite low compared to what we see in a lot of the trials and the real-world data coming through. But this is the reality when you take people with very higher HbA1cs, the final time in range tends to be a bit lower, as we see here. But when people were coming back to my clinic on these systems, they were saying, Emma, this is life-changing. And that's reflected. 97% would recommend hybrid closed-loop therapy to other people. So reduction in HbA1c, improvement in time in range, and again, we knew that from the randomized controlled trial data. But this reduction in diabetes-related distress, with a baseline of 69% reporting diabetes distress, being overwhelmed by living with diabetes, feeling like they're failing, reducing to just 23% is staggering. And actually, in England, NICE have evaluated all the randomized controlled trials and the real-world data together and have put together recommendations for access to hybrid closed-loop systems in the UK. And I am delighted that in my country, we are now going to be legally mandated to deliver automated insulin delivery to people who meet the following criteria: an HbA1c above 58 millimoles per mole, those with disabling hypoglycemia, those who are pregnant or planning to become pregnant, and all children and young people. And this is all people living with type 1 diabetes, and I'm really excited about delivering this in my clinical practice. So from the decades of research that Roman has done, here we are now in a position to actually be able to offer this technology and change lives. So to walk you through some of the features of the CamAPS, MyLife CamAPS FX, here you'll see that you've got the app in the mobile phone with the pump, and then an option of sensors. We've got compatibility here with the Freestyle Libre 3 or the Dexcom G6. And I'm sure you're all familiar with the concept of automated insulin delivery, but you see it demonstrated here at the bottom. The glucose goes up, the system delivers more insulin, the glucose is falling, the system's delivering less insulin, working hard behind the scenes to ensure that person's glucose stays in the target zone. A unique feature of CamAPS is the personal target range, which is down at 4.4, which we may get to in someone, for example, in pregnancy that needs really tight control, up to a glucose of 11, which allows us to really personalise how that automated insulin delivery is working for the person living with diabetes. You'll see on the app here as well that we've got boost and ease off options. And the beauty of this is, say for example, somebody is planning to go for a walk, they can set ease off so it gives less insulin. If they're having a day where they're quite stressed or maybe fighting off a cold or something, they can set boost and it will give them more insulin. And I love the fact that actually this is a word rather than setting a target glucose. There are many people in my service that really struggle with their numeracy, and saying to them that you need to set your glucose target higher to get less insulin can be difficult to comprehend for some people, and actually having the words can be easier to interpret. And we're going to hear from Othar later about exercise and diabetes, but I'm sure you have seen this yourself. So many people with type 1 diabetes are scared of undertaking physical activity because of the stress. How many carbs do I need? How much do I need to change my insulin? Checking glucose levels frequently. Here was an example, going for a 2-hour walk, set ease off, and the system works behind the scenes, maintaining that glucose in the target zone. Beyond that, one of the most terrifying things with type 1 diabetes, and I've got type 1 diabetes myself, so I can speak from personal experience, is going to bed not having a clue what your glucose will be when you wake up in the morning, or whether you'll experience hypoglycemia overnight. And this system, again, is working behind the scenes when the person's sleeping to ensure that they wake up with a glucose in the target zone. And my goodness, for parents with young children, this is a godsend. That ability to go to sleep knowing the system's got your back. Now, another thing, and I am again speaking from personal experience, wearing a dress, when you want to give a bolus at a mealtime, if you need to physically go and find the pump and take it out and press buttons, when you're a woman wearing a dress, and it's International Women's Day, so this is a consideration that affects half of the audience. But it's actually a real pain if you have to fiddle or go to the toilet to pull out your pump and press buttons on it. And one of the things that's fantastic here, it's on the app and you can bolus from your app without having to touch the pump, which the men in the room may not get, but the women definitely do. And then carbohydrate counting. So we all know that carbohydrate counting is difficult. Even for the most skilled people, it's difficult to get accurate all the time. And the reality is, if your carbs aren't quite right and the glucose goes higher, the system will see that, deliver more insulin and bring it down. And it means that people with diabetes can be less worried about the need to get their carbohydrate counting correct. And we're going to hear much more about that later today as well. And coming back to numeracy issues, if you can't carb count, you're not sure about the numbers, another great thing here is instead of putting in the number of carbs, you can choose the meal size. So for people that really struggle, I sit them down with my dietitian, they go through the day and they work out roughly what they tend to have for different meals so that they can pick the size of the meal rather than having to think about numbers again. We've then got tailored alerts that you can see here. We've got add meal function, particularly useful in hypoglycemia, where they can tell the system they've had treatment for hypoglycemia and the system knows that that's what's happening. And of course, the ability to share across with all your loved ones, etc., that may want to share your data. And of course, time and range. The whole language of diabetes in the clinic has changed, and we very much talk about time and range rather than HbA1c when we're talking about goal setting. And people can go into the system and at a glance look at what their time and range is and monitor their progress from day to day, month to month. And in terms of the real-world data, here we have data that were published from 1,805 MyLife CAM-APS hybrid closed-loop system users. And you will see there's an impressive time and range of 72.6% across all users, time below range of 2.3%, so very much in line with the international recommendations, and a GMI there of 6.9%. But for me, it's the lived experience of the people with diabetes, and these are just some of the comments I hear in my clinic. Life-changing. My mood's much better. I spend far less time worrying about my diabetes. But I particularly like the woman that came in and said it's like being married to a different man. He's far less moany and irritable. But I mentioned before that if there's ever a time where glucose control matters, it's in the context of planning pregnancy and in pregnancy. And again, on International Women's Day, two absolute inspirations, Helen Murphy and Eleanor Scott, who led the ADAPT randomised control trial comparing CAM-APS with MDI and CGM. And they were able to demonstrate a significant improvement in mean-adjusted difference in time and range of 10.5%. An important message here, it doesn't matter what HbA1c level the ladies are coming in on, they are achieving fantastic improvements in glucose control, and that really matters in terms of outcomes for both the mother and the baby. But I'm going to put that in context by just sharing a case from my clinic. So this was a 29-year-old female who'd had type 1 diabetes for 5 years, and she presented with an unplanned pregnancy at 10 weeks. Her HbA1c was 12%, and actually we would typically have suggested that she avoid pregnancy with this level of control due to the very heightened risk to both her and the baby. But we're pregnant now. She's not been monitoring her glucose levels at all. She tends to eat a lot of sweets and chocolate. She's got no idea what's happening with glucose. So we saw her in clinic, supported her transition back onto glucose monitoring, and aimed to start to support her. So this is the initial Freestyle Libre that we put on in clinic, and you can see here the time in the pregnancy target range was 22% when we're aiming for more than 70. But we started to work with her, supporting her with carbohydrate counting, developing ratios for meal times, corrections, and encouraging her to get back into the way of giving her boluses before the meals, which was something that she hadn't really been doing. You can see that she then started to improve her time and range, despite all of this, was remaining low at 18%. And we really had our work cut out. Every single day matters in pregnancy. We want to minimise the amount of hyperglycemia that baby's being exposed to. So we spoke to her about CAM-APS, and she said, yep, I'm happy to go across. And literally within 2 weeks, she managed to improve her time in range to 49%. And if I put these just together here, you can see that a dramatic improvement. And despite all the support that we can give, this simply would not be possible with all the challenges that she had in her life. 18% up to 49%. Moving through pregnancy, she was able to further improve her time in range. Now we're up to 58% time in range, again with weekly support, intensive support to really drive that time in range as high as we can without her experiencing too much hypoglycemia. And again, these are just highlighting these are common conversations we have in clinic. One of the key things that we need to support women and outside of pregnancy with doing is trying to give the bolus before the meal. This is an incredibly difficult thing to do. But especially in pregnancy, it really makes a difference to get the insulin in. And Helen Murphy talks about 15 minutes pre-bolus in the first trimester, 30 in the second, and then up to 45 minutes in that third trimester. But it is a really difficult behaviour to do consistently. And you can see the impact that that has on the time in range. We're losing time in range here because the boluses are going in late. So again, we're trying to support her with behaviour change around that. So ongoing intensive education and support, optimising those insulin to carb ratios, supporting her with that carbohydrate counting, tightening the glucose targets as the pregnancy progressed, and we're generally looking at starting a target glucose on the system of 5.5 in early pregnancy, and then moving to 5 millimoles during the day and 4.5 during the evening and overnight if possible. But again, of course, we're individualising, encouraging her to bolus before the meals and optimising dietary intake. And this is the before and after. 22% time in range at the start of pregnancy, from somebody that had not engaged with diabetes services prior to pregnancy to now being at 65%. A huge improvement. And she managed to have a healthy baby from what started off as extremely high-risk pregnancy. And actually, my antenatal clinic now, this is my recurring experience. Women are doing so much better. It's just a joy to support them. But ideally, we want to get women on a hybrid closed loop prior to pregnancy so that they're entering pregnancy and they go through the first trimester when organogenesis is underway with excellent glycemic control. And that's what we are working to achieve in the UK now with the updated NICE guidelines. And just to finish, this is the other end of the spectrum. So I have many people coming through my clinic now who meet the criteria for access to hybrid closed loop, and we're having discussions about how we're going to arrange to transition them. So this is Tom, who's 45 years old. He's had long-standing type 1 diabetes. He's got laser-treated retinopathy, and he's sadly lost sight in his left eye. He's also got progressive nephropathy. He's on multiple daily injections. He has had a chronically elevated HbA1c, currently at 102 millimoles per mole. He's missing many doses of insulin, and he struggles with his mental health, and that impacts on his ability to self-manage his diabetes. But he's come into my clinic saying, I'm really keen, I've heard about these closed-loop systems, I'm really keen to move across. He says he also feels hypo if his glucose gets down at 7, and that's why he likes to run high. So I am all for getting Tom onto hybrid closed-loop because he is a young man with complications, and we need to get his control to a level that is going to prevent him from having further development of those complications. But there are a number of things here that we need to think about. So first of all, he feels hypo at 7. I have had people in my clinic who've gone across to AID from a similar situation, and then if you go from having no hypos to even, as healthcare professionals, we think 1% or 2% hypo doesn't sound high, but if you're a person living with diabetes that doesn't want any hypos, 2% may not be acceptable, and I have had people hand back their AID system because they don't want any hypoglycemia. So CAM-APS for him, I think, would be perfect because it's got that range of glucose up to the 11. I can put him on a high target and work with him to gradually bring him down. The other thing, of course, here is the fact that he's only got sight in one eye. We know there's a small but potential risk of early worsening of retinopathy. So I'd want to be liaising with his ophthalmologist, making sure that they're seeing him regularly and getting him gradually down into his target range, but in a way that he is going to feel comfortable and that he engages with the system, he feels it works for him, so that we eventually get him right down to the target HbA1c of 48 millimoles per mole, but in a way that is not going to feel that he's supported and that he's got there safely. So, in conclusion, there have been dramatic advances in diabetes technology in recent years, And a huge thanks to our chair, who literally, I told him it earlier, you are the man that is changing lives. I am delighted to be associated with you. It is life-changing technology, and in my experience, there's no better intervention for the management of type 1 diabetes. But if we're delivering this technology, we need to make sure the systems are tailored to the individual, that they meet their needs and they feel supported, and that the system works for them. CAM-APS, in my opinion, offers great flexibility to the users and delivers improvements in both HbA1c and time in range at every end of the spectrum, from the women that are needing really tight control with the lowest target in the system of 4.4, right up to the gentleman, Tom, that I described, that we may need to bring him down more gently. So, thank you very much.
Thank you very much, Emma. I think it's very much true that we have the systems. Now the issue which arising is to get it out to people, and I think this is where we really need dedicated clinicians and also right processes. Along this line, I'd like to invite Dr. Leah Bali from University of Bern. I know Leah for a long time. She came to Cambridge some time back, and she established a fantastic research group in Bern working on nutrition, and she will be sharing with you information about how to simplify meal entry into the CAM-APS. Leah, please.
Thank you, Roman, for the kind introduction, and thank you for the invitation to speak today about a topic I'm very enthusiastic about: simplification of meal management with the MyLife CAM-APS FX system. So these are my disclosures. So, as you all know, the use of AID has dramatically improved glucose control, but you can also see on this 24-hour sensor glucose profile in red of AID usage, and gray the comparator, which is pump therapy here, that we still struggle with meal management. So we always see this pattern that daytime glucose control is inferior to nighttime glucose control. And these meal-related glucose excursions are clearly related to carbohydrate intake. Carbohydrates are the main meal macronutrient that actually causes these glycemic excursions, and this is also the reason why we educate people in carbohydrate counting. But carbohydrate counting is not straightforward, and also the relationship between carbohydrate intake and meal-related glucose excursions is not linear. It's actually complex, and we know that the physiology of postprandial glucose metabolism is complex because it's not only about the quantity of carbs, it's also the type of carbohydrates. So starch impact glucose control differently than sugar. We have other factors that play a role. For example, if people are exercising before, if they pre-meal bolus or not. And secondly, carbohydrate counting is really perceived as a burden of self-management. And if we ask people with type 1 diabetes, more than half really perceive that as an annoying and often also time-consuming task if you want to do it properly. And it's also very challenging to estimate carbs accurately. We know that the human eye is really bad in estimating sizes in 3 dimensions. And I just want to share with you this overview visualizing carbohydrate counting errors in a large study. So you see on the y-axis the carbohydrate estimate by patients, and on the x-axis the reference method, and you can see that people tend to overestimate carbohydrate content of small carbohydrate portions, and they underestimate usually carbohydrate contents of large meals, so carbohydrates more than 60 grams of carbs. So with the widespread use of AID systems, we are increasingly aware that if we use adaptive glucose control algorithms, this may provide forgiveness for imprecise carbohydrate counting. And you can see here the physiological framework of the MPC controller of Roman Hovorka. And this is a very adaptive closed-loop algorithm that can actually estimate the meal carbohydrate that appears in the blood from the data. And you see, for example, here an example where the carbohydrate quantity was clearly underestimated by the bolus, but the algorithm can actually kind of smoothen that out by its adaptivity. But even if we know that if we look at all the commercial systems that are on the market, the majority of the systems still require the users to actually enter the exact amount of carbs into the bolus calculator, so with 1 gram precision. And as I mentioned, the related burden, it's important to really balance burden against benefits. For example, in youth and young adults, this balance is really important if we want to ensure optimal uptake of technology, adherence to the treatment and engagement with the system. You know that youth and young adults are still the age group with poorest glucose control if we compare it to other age groups. And this is also the reason why we have recently conducted a randomized clinical trial in Switzerland in 2 sites, University Hospital of Bern and University Hospital of Zurich, in youth and young adults, where we really wanted to challenge the concept whether exact carbohydrate counting is still necessary and whether a simplified meal approach cannot achieve similar glucose control. If you want to really learn more about this study, I would like to encourage you to visit the oral presentation presenting the scientific results, which takes place tomorrow. But I briefly want to show you some details of the study, some insights. You see here on the right-hand side the bolus calculator of the MyLifeCam APS FX system. You have 2 options. You can either enter the exact amount of carbs, or you can actually choose pre-programmed meal carbohydrate contents. And these meal carbohydrate contents are actually adjustable, so it really makes sense to pre-program them and adjust that to the eating habits of a specific patient. So how does that look like in practice? I'm going to share with you here an example of exact carbohydrate counting sensor glucose profile over 24 hours. And here you see the algorithm-directed insulin delivery, and you see here the bolus that were manually delivered, and this is with simplified meal announcement. So we just pre-programmed meals to 50 grams, 100 grams. So that was actually the medium meal, that was the small meal, that was the large meal. And below you can see an example where a subject actually did exact carbohydrate counting, so meaning entering the exact amounts of carb into the bolus calculator. And just briefly, you can see here the sensor glucose profile of the simplified meal announcement period. In blue, that was a crossover trial, and in green, the exact carbohydrate counting period. And it's visually obvious that there was actually very similar level of glucose control, and this study has confirmed non-inferiority of the simplified meal approach with the MyLifeCam APS FX system. So these are the key primary and secondary endpoints, and again you really don't see a difference in the key glucose metrics, but you can also see that there was a slightly higher amount of automated insulin delivery in the simplified meal approach group, and that makes sense because that reflects the correctiveness of the algorithm. So it's also important to know that this study was the first hybrid closed-loop system study that showed non-inferiority of a simplified meal approach. Other studies were published investigating simplified meal approach with exact carbohydrate counting with other systems, and they still showed superiority of exact carbohydrate counting. So keep it simple is really the message here for this target population. And the second simplicity message, and we came across it in Emma's talk already, is it's very important to pre-bolus. I think that's probably one of the most frequent optimization counseling topics I have in clinical practice. So these are several examples where you see that people bolus too late, or they bolus several times when the algorithm was already stepping in, and that leads to suboptimal postprandial glucose control with higher levels in the early postprandial period and lower levels in the late postprandial period. So to conclude, adaptive AID systems such as the MyLife CAM-APS FX system may provide forgiveness for imprecisions in carbohydrate counting. So the message here is really to keep it simple. It's very important to bolus upfront. It's important to cover the carbohydrates, but the coverage can actually account for 50 grams carbohydrate portion sizes, and it often does not make a big difference if you enter 22 or 25 or 28 grams of carbs. It's very important to choose the meal bolus approach with minimal burden to maximize treatment adherence and to maximize the uptake of the technology. And this is, of course, a very individual topic. So the user should have the choice to actually go for the method that suits its personal needs the best. Thank you very much for your attention.
Thank you very much. Thank you very much, Dr. Bali. Meal is difficult, but another thing which is difficult is exercise. Exercise with type 1 diabetes, with or without AID, continues to be challenging, needs to be personalized, and there's no better person to talk about it than Ottmar Moser, who is specializing exercise, and he split his time between Germany and Austria as well. So welcome. Thank you very much.
Thank you very much for the opportunity to discuss with you together, guys, the importance of exercise in people living with type 1 diabetes, and also going into detail how we can use the MyLife CAM-APS system around exercise to, first of all, show it can be used safely in people with type 1 diabetes, and secondly, we are also extremely efficient using the MyLife CAM-APS system. So this is my conflict of interest. So first of all, we need to discuss the fragile relationship between type 1 diabetes and exercise. You know, there's this love-hate relationship in people living with type 1 diabetes when we are discussing with them the topic being physically active or doing exercise. Because there are many risks for people living with type 1 diabetes, but at the same time we have different beneficial effects when people with type 1 diabetes are regularly exercising. Then we will lose ourselves in detail into the topic, what can we do individualized for the CAM-APS system, and how can we use it to support people living with type 1 diabetes around exercise. You will be the first one seeing some new data out of our ongoing trials, what will be done in the future, what can be recommended, and we will have at the end a small conclusion. So what is the main reason for people living with type 1 diabetes not to exercise? And these are novel data from 2022, and it's clear and it's still the same issue. Fear of hypoglycemia is the major trigger not to exercise. But what was novel in this study, that it also showed it's the same for parents of kids living with type 1 diabetes. So we clearly do see most of the people living with type 1 diabetes are afraid of hypoglycemia, but additionally, they are afraid of hyperglycemia. So we need to tackle both. So not just solely focusing on avoiding hypoglycemia, we need also to focus on avoiding hyperglycemia and support people that they are not afraid of loss of chronic diabetes control. So the risks, are the risks really there? And the answer is yes. 18,000 people living with type 1 diabetes were assessed if they were physically inactive, moderately active, or intensely active. And they were assessing the rates of severe hypoglycemia events by 100 patient years. And what do we see here? This classic U-shaped relationship. So what does that mean? Those with type 1 diabetes who are regularly exercising and those with type 1 diabetes who are not exercising are those people with the highest risk of severe hypoglycemia. Let's focus on the gender. We see this difference a little bit more separated, but very interesting for the very, very old people, so above the age of 45 in this study. We do see a very interesting difference in the increased risk. Yeah, I'm also old. Looks like that. We do see the opposite. So those who are intensively exercising with type 1 diabetes and are above the age of 45 are facing the highest risk of severe hypoglycemia, and this is the thing we need to work on to improve this. So my good friend Mike Riddell did a very nice study where he was assessing in children and adolescents with type 1 diabetes days the kids were physically active and days the kids were not physically active. So below the 200 meds means they were not really active, moderately active means between the 200 and 600, and above the 600 means they were really active. And what do we see here? The mean glucose is lowest on days kids with type 1 diabetes are physically active, and at the same time, the time in range between 70 and 180 milligram per deciliter goes up. So this is such an interesting result and very important to understand. The time above range level 1, so above the 180 milligram per deciliter, and 250 milligram per deciliter is also decreasing. So we have a multipotent drug, exercise, but we only need to use it in people with type 1 diabetes to improve clinical metrics based on CGM data. So let's go into detail. How can we use the KMABS system? And it would be too easy only saying start ease off at the onset of exercise or 2 hours in advance. So we did in the last years recommend in different recommendations and consensus reports the therapy needs to be individualized based on an expected glucose response. So what is the timing for planned exercise to adjust? So at least it should be adjusted 90 minutes in advance to exercise. But previous data did show 120 minutes in advance to exercise might be better. Is there a chance that the prandial insulin dose needs to be reduced? Yes, in some cases, especially when the meal is consumed very close to the exercise session. What can be done with the KMABS system? And this is quite interesting. We have the special feature of ease off and boost mode, and this is not included in the algorithm learning. So this might be a perfect choice for people living with type 1 diabetes who are not really regularly exercising. For those people who are exercising every day at 5 p.m. in the evening doing the same exercise session, it might be recommended setting the target and not just solely starting the ease-off mode. So we can set the target for exercise between 80 and 200 milligram per deciliter, and this is a perfect choice for regular exercises with type 1 diabetes. So what can be done for spontaneous exercise? And this is quite clear, and this is recommended from previous studies in non-automatic insulin delivery. So when you want to start exercise, and this is a spontaneous decision, start a new target or ease off or boost immediately, use the time, set it on, start it. Consume carbohydrates at the onset of exercise immediately when you start, perhaps between 10 and 20 grams of carbohydrates, when you expect a decrease in glucose concentration, which is mainly seen for low intensity exercise, moderate intensity exercise. We quite often see for high intensity exercise or interval exercise an increase in glucose levels. If the glucose target during the exercise session is not achieved, for example, you set it at 150 milligram per deciliter, try to support the system early, already at 126 milligram per deciliter with microcarbs. And this is a very important information. If you see the target is not held, don't consume 50 gram carbs, consume very small amount of carbs to support the system. Always check the trend error on your CGM device and check the insulin on board, which you can easily assess on your display. So what can be done for exercise sessions where significant glucose decrease is expected? You should you should start the ease off mode and higher the glucose target to the 150 milligram per deciliter. Consume carbohydrates already at a 126, and this should be at least, for example, 6 gram carbohydrates. Always check again the insulin on board and also the trend arrow. What can be done for mild glucose decrease? So start the ease off mode, set the glucose target at around 120 milligram per deciliter. Consume carbohydrates early. When you set it at 150, consume it already at 126, but a little bit less amount of carbs, around 3 gram carbohydrates. Again, check the insulin on board in the system. Stable glucose, so this is, for example, for moderate intensity exercise. Very easy, use the ease off or define the new glucose target at 150, and again, consume carbohydrates, around 3 gram carbohydrates to support the system. Always check again insulin on board. So it's quite a similar information, but again, we do individualize it. We do not just solely support the 150 or ease off mode. So what can be done for an expected increase in glucose? And this is important, for this normal person being 25 years old, going to the gym, getting a big biceps. So what can be supported? How can we support this person? Set the glucose target at the 120. If required, set the boost based on the insulin on board and inject a regular dose of prandial insulin. Significant glucose increase is expected, and this is always a hot discussion with our people living with type 1 diabetes. You do see in our outpatient clinic, perhaps define the glucose target at 80 milligram per deciliter, and at the onset of exercise, additionally, start the boost mode. So this is extremely aggressive, but this holds true for people who are going up to the 400 milligram per deciliter during the exercise session. Inject the regular prandial pre-exercise bolus insulin dose to avoid severe hyperglycemia around exercise. And now you're really the first one seeing some new data of our ongoing trial. So this is our in-loop child study where we are assessing in general if it's needed that children and adolescents with type 1 diabetes need to reduce the prandial insulin dose in advance to exercise, and I am only allowed to show you now the CBX data, so the glucose response during cardiopulmonary exercise testing, a maximum exercise test in this young group of people with type 1 diabetes. Age 12 years, an HbA1c of 6.9, type 1 diabetes duration of 2.5 years, and a time in range of 69%. From my point of view, this is quite good, to be honest, if these kids are already running on the MyLifeCame APS system. So what was the recommendation we gave to these kids with type 1 diabetes in advance to the maximum cardiopulmonary exercise testing? So it's an extreme, intense exercise session, but at the beginning, it starts with extremely low intensity. So we did not know what is going to happen during the exercise session. So this was the main reason why we fixed the glucose target at 150. We started the ease off both 2 hours in advance to the exercise session, and these are, as I did say again, preliminary data. So this is the normal lactate response we did see, and believe me, it was quite strange grabbing lactate of 8-year-olds from the earlobe every minute, collecting blood of them, but it did work quite well. And even the exercise intensity extremely went up. As you see here via the lactate, the CAME-ABS effect system was absolutely capable to stabilize the glucose. So we had a stabilization at around the 180 milligram per deciliter. There was no drop, there was no increase, and this was automatically supported by the MyLife CAME-ABS system during exercise with changing the basal rate during this type of exercise. So we were absolutely happy with this data. Making it a little bit more intense and losing ourselves again in detail, and I need to show this data as an Austrian, so this is clear, discuss with you now the ski data. So we performed also a ski study with children with type 1 diabetes, again, this group using the CAME-ABS system. So the age was 12 years, HbA1 6.8, and the time in range in this group before the entry in the study was 73%. What did we hear in this study? And this was quite intense, to be honest with you. So for each of the skiing sessions, we started the ease off mode 2 hours in advance to the skiing session. If we did check the glucose in advance to the skiing session and the glucose level was below or at the 130 milligram per deciliter, we gave already 12 gram carbs. Why? Because we were in a postprandial state without the bolus insulin dose reduction. During the skiing camp, we did the following stuff. So below the 130, we gave 3 up to 6 gram carbs. Below a 100 milligram per deciliter, we gave 12 gram carbs. And at the 90, based on the recommendations, we stopped the skiing session and we gave at least 12 gram carbs. And when I see these data, and now it's been a couple of weeks since we are back from the skiing camp, it was our mistake. We were much too aggressive, to be honest with you. So what happened during the entire ski camp? So over 2 days and 4 times 2 hours of skiing, the MyLife CAME-ABS system were absolutely capable to support the kids. We saw a time in range of 62%. We saw a time below range of 3.9%, and clinical relevant hypoglycemia was more or less not existing. Afterwards, I need to say honest, we were too aggressive, as I did say. I think if we would have been more relaxed, it would have been easier for the kids living with type 1 diabetes. So what are my conclusions? The MyLife CAME-ABS system offers so many opportunities for people exercising with type 1 diabetes. So we need to use all these opportunities and not just using, for example, the ease-off mode. These opportunities need to be adjusted based on the glucose response to exercise. So again, for low intensity, moderate intensity, high intensity exercise, or for example, for interval exercise sessions. If possible, most therapy adjustments should be performed 120 minutes in advance to exercise, but we also did see it also works for spontaneous exercise. However, for spontaneous exercise, higher amounts of carbohydrates might be needed, and even under extreme conditions like a skiing camp, the MyLife CAME-ABS system was safe. So I do absolutely recommend using these recommendations in future, and perhaps in 2024 a new position statement will come out where we will be discussing the use of HCL systems around exercise with these great people, Desi and Mike Riddell. It was my pleasure being allowed talking to you, open for questions and discussion. Thank you so much.
Thank you, Ottmar. Thank you, Ottmar. If you need some help with your skiing camps, I'm happy to come and join you there as well. We have some time for questions, so if you introduce yourself, we have about 10 minutes. And it could be questions for all the speakers, please.
Yeah, Christophe de Blok from Antwerp, Belgium. Thank you, Ottmar, and a very nice presentation. In practical terms, many of the patients ask, when should I bolus before starting exercising? And should I reduce the bolus, yes or not? So can you give us some advice on that?
Now you should hear me, hopefully, yeah. So when carbohydrates are consumed within 1 hour in advance to exercise, we would recommend reducing the Brandyal dose by 25%. Everything that is above this time period, just for KMAPS, the system should be capable to avoid hypoglycemia. If you have a person who is always extremely close to hyper, then we would recommend also reducing the Brandyal insulin dose by 25%, even 2 hours in advance to exercise. But this could happen, then the basal rate goes up, and then you're still again low in advance to exercise. Perhaps the 1 hour recommendation might be okay.
You don't see hyperglycemia in the 1 hour?
Hyper? It's depending. So with the first recommendations, we quite often see hypoglycemia because we go always in with the first recommendation, start the ease off. Then check your glucose response to the exercise session. And then in the following sessions, we try to avoid not just hypoglycemia, but also hyperglycemia.
Hello, Mikael Rinetmäki, a patient currently wearing CAM-APS and also an entrepreneur. So SensoTrend does service that provides more information from exercise, especially from these gadgets. So my question in general, currently it's possible to share the data with Gluco. How about with other services like Tidepool or with SensoTrend? What's your relationship there? I guess it's for Roman.
I'm not sure I understood the question there.
Data sharing. So we want to combine data from all these wellness trackers to the data that we get from CAM-APS and visualize that together so we can see here you did this kind of exercise and here's how it affected you.
Thank you. The issues of integrations of various technologies, including trackers and into the closed loop system. You mean getting the data from tracker into the closed loop system, or getting data from the closed loop system into your smartwatch?
Well, my specific example is that we do a service like Gluco, but with additional visualizations that to take the information from smartwatches and other exercise trackers. So you can actually, as a patient or a healthcare professional, view that data. Here was this kind of exercise and that was its effects.
Yeah.
So.
I think there's maybe Otmar would be better positioned. So I think the question of getting data from trackers into the system. So this is question number one. What I learned is that in the closed loop system, you want to use information which is reliable. And some of those exercise tracker will be tracking when you're on the bus and other things, which you get not necessarily reliable information. There are people who are working in this space using trackers as well. At present, I am not absolutely sure it's going to help you because, for example, you will get the track information from the time you starting exercise, not 2 hours ahead of that exercise. And there's lots of noise as well. So that's the balance whether that information is reliable. And currently, we're trying to make the system as simple as possible and use the information which is reliable. So that's sort of the bigger picture. Getting data from the system to the smartwatch, again, it's issues of integration. There's so much variability of devices and so many different devices and possibility for things going wrong. And because this is a medical device, one needs to be really careful which way you do it. So you might understand that sort of the iOS system is more closely integrated, unlike the Android system where you have lots of different manufacturers and the possibility for data not flowing correctly and timely is there. So these are the things where we want to think about and put priority where we should put our resources. But we see that people want to see data on the smartwatch, but we don't also want to see people calling on the customer service saying, my smartwatch is not working. So that's the balance.
Thanks.
I don't know whether Otmar wants to comment on the exercise information into closed loop system as well.
Yeah, perhaps one sentence. We do have a built Excel file where we afterwards put all the data together. We put also the data together for continuous ketone measurements, continuous lactate measurement, and to help afterwards, retrospectively, a deeper insight into the data. But as Roman was saying, it's about the accuracy, and if there is a wrong detection of exercise, then this can be fatal. I have also type 1 diabetes, and we are testing so much stuff also on myself. I'm still sitting here, so everything's good. But it's tricky, to be honest.
The other feedback is for exercise recommendations. So you talk a lot about insulin dosing. What I've learned is crucial is also the timing of meals before exercise, and I don't think I saw that in the recommendations. I think that should be part there. So if I eat 1 hour before exercise, it's really hard to manage. However, if I eat 2 hours before or half an hour before, it becomes much more manageable. So have you considered that?
Yes, so I just had 15 minutes here in the ESD ISPED position statement. We will have around 70 pages, and this will be included, but time was limited, but we can discuss afterwards on an espresso outside, so more than happy to do so.
Thank you.
Thank you so much.
Hi, Caretta from Milan. Wonderful presentations. A question about exercise, very clear about the amount of carbohydrates. Should we also consider the different kinds of carbohydrates, in terms of glycemic index according to different glycemic values or type of exercise? Very practical question, thanks.
So I'm not sure if I got the question. So the different glycemic impact of different types of carbohydrates in the context of the exercise?
Yes.
Yeah, so that depends. If it's like preventive carbohydrate intake, then I would definitely go for a slow acting carbs. So not glucose. And if it's like for hypoglycemia correction, tiny amounts of fast-acting carbohydrates, so glucose.
No.
And
if I can...
Yeah, I would just want to add to that. I absolutely agree. I think what we want to avoid is that if you get too much carbs during exercise, the system starts giving insulin, and it's a problem as well. So anyway.
I have 2 questions. Marit Hamir from Luxembourg. Oh, sorry. One question, what you do with contact sport, for example, ice hockey. And the second question, because I have kind of a lot of patients who wants to be as low as possible, who introduce false carbohydrate. Is the system can correct that?
Not sure whether I understood the question. Never use fake carbs in this system. It's not necessary. It doesn't make sense at all.
Yeah, I know, but there are patients, I don't know how another experience, because I have some patients who want to be as low as possible, not for exercise, whatever. They don't want to have at all increase, and usually AID always react a little bit slower than automatic system reacts slower. How we can recognize this in the system?
So you can give you can give a correction bolus, so you don't need to put carbs. If people want to be more aggressive, they need to be careful, because I know in Luxembourg, people some of them try to run very tight, so I would be very careful. But it's possible in the system, unlike some other systems, you can do just correction yourself based on the glucose, so you just dial the insulin in there, so it's possible. Be careful.
Yeah.
And for the ice hockey, perhaps one sentence, what we do with professional athletes, for example, ice hockey players, we do define the different exercise sessions they do have. They have normally a portfolio of 10 different exercise sessions, and we have then for each exercise session a specific individualized recommendation. So if you want to be a professional athlete, for example, with type 1 diabetes, you have to be a professional person living with type 1 diabetes. So it goes hand in hand, and this is how we do it, and this works quite well. If it's a normal person just playing sometimes ice hockey, then always go safe in with a higher target and ease off, and then after afterwards define again if you need to lower the target or, for example, go in with a boost mode if there is an increase in glucose seen.
But during the training on ice, you remove it because they can crash the pump.
Okay, you mean this is the risk of being an ice hockey player. This is life, and this is type 1 diabetes, and we just need to support to find a solution. And worst case, and I'm really sorry to saying that the pump is breaking, but this is worst case scenario, but then we have great support by the pharma reps that you are receiving a new pump. Sorry.
I think in the UK it's not a problem. There's a famous cello player who has type 1 diabetes, and I think you don't want your alarm going through part of your performance. I think he doesn't actually wear it at the time. I'd like to actually plan one question for the panel as well, which I didn't discuss with them, so it's a surprise for them. I think we discussed professional exercise people or sports people. I'd like to see other professional healthcare professionals who have type 1 diabetes. We have some here on the panel as well. And my experience is some of them are not doing very well because they are really busy with their life. What is the advice for healthcare professionals running closed loop? How should they manage their type 1 diabetes with closed loop systems? With my life or without my life, come here, Piers.
Well, my advice is just be on the system in the first place. I look back on my days as a medical registrar running down the corridors to cardiac arrest when I was on multiple daily injection and finger pricking my glucose, and my control was not as good as it could have been because the thought of having a hypo when I'm trying to save somebody else's life just wasn't an option. And I am genuinely delighted that the doctors and everybody, all healthcare professionals working in really stressful environments will now have the opportunity to use technology that will allow them to get on their job without, I have got onto the stage today without even looking at my glucose because I know the system's got my back. And again, just before closed loop, I would have been eating Haribo because I'd rather speak with a high glucose than worry about the hypoglycemia. So to be honest, it's not about the nitty-gritty. The whole idea of these systems are that they are simple, easy to use, and they lessen the burden of diabetes. So there's no complicated formula about making this work. It's just put on the system, go with it, and worry less about diabetes.
I keep it short and simple. So I was 20 years running on insulin pen therapy. And since I'm running on the MyLifeCam ABS system, I do forget at work that I have type 1 diabetes. And this is, I think, the main message. I do forget it, and this is the very first time after 20 years. Yeah.
Thank you very much to the speakers, to the audience. Enjoy the rest of ITDD, and thank you for coming.